Hi everyone. So this week also we're going to continue our lecture series on biologicals and psoriasis, and fortunately this would be the last video in that series. Of course we may do some additions in the future, but with this video we are going to wrap up this collection of videos on the various biologicals that we usually use, some of them that we don't usually use, which have been FDA approved and have been in use to treat psoriasis all over the world. Now, what's the point of learning about other biologicals which we don't use? Many of them are not available in India, and why should we know about them? Now, the reason why I wanted to do this video and complete the series as a whole and finish it was because that many a times we might get these drugs available in the future, so we should know about them, number one. Number two, sometimes the patient comes to us and asks about these drugs, so we must have some idea how they're going to act. And number three, the more we read about different types of drugs and their mechanism of action, we kind of strengthen our understanding of psoriasis. And why do we have different responses when we use different biologicals, and why one biological will work wonderfully in one patient and the same, and different biologicals going to work differently in the same patient. So just to develop a holistic understanding of why different biologicals show their action in a patient of psoriasis, so I decided that I'll finish the three remaining biologicals which are used in treatment of psoriasis, and thus today's video will focus more on interleukin-23 inhibitors, the remaining which are Guselkumab, Tildrakizumab, and Risankizumab. Now, all of these three biologicals, Guselkumab, Tildrakizumab, and Risankizumab. Now, these are interleukin-23 inhibitors. Now, how do we explain their actions? For that, we need to go back and revisit the video on psoriasis pathogenesis and how interleukin-23 plays a very important role. After you have gone back and listened to that video once again, I request you to go back and see the video on Ustekinumab. Now, Ustekinumab is a combined interleukin-12 and 23 inhibitor, and since it blocks these two cytokines, a lot of mechanism of action of Ustekinumab is shared by these three biologicals. So let's start our story by just revising in 10 or 20 seconds. How do we know about action of Ustekinumab? Okay, so let's start with Ustekinumab first. Now, Ustekinumab is a combined interleukin-12 23 inhibitor. Now, why is it a combined inhibitor? Because it acts on the P40 subunit, and that P40 subunit is shared by both of the receptors. This is the 23 receptor and this is the 12 receptor. Okay, and both of these receptors share a combined subunit 40. And since Ustekinumab blocks P40 subunit, it blocks both of these receptors. We are clear on that? But today we are going to talk about interleukin-23 inhibitors. That means only this section of Ustekinumab action. Okay, only this section. So let's go forward. So let's see what do we mean by interleukin-23 receptors and P40 subunit. Now P40 subunit is blocked by Ustekinumab. We are clear on that? When further studies were carried on P19 subunit, it was found to be elevated in patients of psoriasis. Okay, and the interleukin the 19th subunit was increased in psoriatic patients. So it was said that we should have biologicals which act on this subunit also, so that individually interleukin-23 action can be mitigated. Clear? So that is why it led to the development of newer biologicals which target only interleukin-23. Okay, so it will be beneficial for all of you to go back and see the video on pathomechanism of psoriasis and how these different cytokines play a role. So it starts with keratinocyte injury, then starts with activation of dendritic cells, and after dendritic cells, it leads to maturation of different T cell lines through the action of TNF alpha. Now, TNF alpha, as we have repeatedly said in the past, it's one of the most important cytokines for psoriasis. Now, after TNF alpha activation of different myeloid lineages of dendritic cells, you have interleukin 23 as a center focus. Now, interleukin 23 will lead to maturation of naive T cells to Th17 T cell line, which will further secrete interleukin 17, and that interleukin 17 is going to continue the inflammatory cascade through its family of interleukins, which includes interleukin 2, 22, and all sorts of other interleukins, and the formation of that scaly keratinocytic plaque. Okay, so that's why interleukin 23 is at the junction of TNF alpha and interleukin 17. And as we have said in the previous videos also, the interleukin 17-22 axis is one of the important axes in psoriasis pathomechanism. Okay, so that is why interleukin 23 is one of the important interleukins to be studied and has a more prominent role in psoriasis. As we have mentioned before, the P19 subunit was found to be increased along with P40 subunit, while the P35 subunit was normal. Now, what is P35 subunit? Remember that Guselkumab acts on both receptors, which is 23 and 12. Both of these receptors share the P40 subunit. 23 has an additional P19 unit and 12 has an additional P35 unit. We are clear on that? So P35 was found to be normal, while P19 was found to be increased. Okay, so it led to the class of thought that we should have specific biologicals targeting the P19 subunit, and that's how these three different biologicals were created, namely Guselkumab, Risankizumab, and Tildrakizumab. And these were the newer biologicals which act via their attachment on the P19 subunit of the interleukin. Okay. So let's recapitulate. Not recapitulate per se. So just to inform that Guselkumab got the approval for use in psoriasis in July 17, Tildrakizumab in March 18, and Risankizumab in April 19, and this approval has been for adult patients. Okay, adult patients with psoriasis which is moderate to severe. Okay, moderate to severe psoriasis in adult patients who are a candidate for methotrexate or phototherapy. So just don't remember that they have to be a candidate for methotrexate or phototherapy. Remember that what do they want to say? That they are approved for adult patients who have widespread severe, moderate to severe psoriasis. Clear? Just remember that. And I've just specified the approval months. Just if somebody would like to ask, what were the order of approval? Now, all three of them bind to the P19 subunit of interleukin 23 and prevents the attachment to interleukin 23 to its receptor. Now, normally, this is the normal pathway in psoriasis. Interleukin 23 is going to activate and lead to formation of Th17, and Th17 line of T cells are going to secrete the interleukin 17 family of protein cytokines, which includes 17A, 17F, furthermore interleukin 22 and additional TNF alpha. Remember that TNF alpha is a part of a positive loop. That means TNF alpha downstream will lead to formation of or secretion of more TNF alpha, and that is how the inflammatory cascade keeps on increasing. So it starts with interleukin 23. Interleukin 23 is going to activate T cells to form Th17 type of cells, which will secrete interleukin 17A, F, interleukin 22 and TNF alpha. Okay, so this is what happens in normal psoriatic plaque or normal psoriatic patient, and when interleukin 23 is prevented from being attached to a receptor by these biologicals, this action does not happen and thus the inflammation dies down. Okay. Okay, so this slide I've taken from Guselkumab video. So just to recapitulate that this here is the interleukin in question, interleukin 23. Now see that all the plasmacytoid dendritic cells or the dendritic lineage of cells are the effector cells, initial effector cells in pathomechanism of psoriasis. Okay, so these are going to activate the myeloid lineage of dendritic cells through interferon alpha, and this interferon alpha is going to activate the subsequent T cells and other dendritic cells. Sorry, I misspoke. This myeloid dendritic cell are going to activate the furthermore dendritic cells, and upon activation, they're going to secrete two interleukins, 12 and 23. But today we're going to talk only about 23. And this 23 is going to act on Th17 cells, which will further secrete interleukin 17 A, F, 22, acting on keratinocyte and forming the plaque. Clear? So this is the pathway that we are going to take. Plasmacytoid to myeloid, myeloid on activation 23, 23 on Th17, and then the plaque. Okay? Let me just draw it in a different color. So it starts with plasmacytoid, goes to myeloid, activation 23, Th17, keratinocyte, and the plaque. Clear? So if you just know this pathway, you can write a lot on the pathomechanism of psoriasis or in about this specific biologicals also if it is asked in the exam. Now this slide I've taken from the pathomechanism of psoriasis. Just to recapitulate, that keratinocyte injury are going to secrete AMPs, DAMPs, etc. And this will lead to the myeloid dendritic cell maturation, the same that we discussed in the last slide, which will secrete TNF alpha, interleukin 23, the cytokine in question today. And this interleukin 23 is going to activate naive T cells to form Th17 T cells along with the TGF beta, IL-6, interleukin 1 beta. So when these chemicals are present, interleukin 23 is going to shift or activate naive T cells to form Th17 cells. Now Th17 cells are the downstream effector T cells in psoriasis, and they will secrete interleukin 17, 22, TNF alpha. So last week when we discussed secukinumab, we discussed the action of interleukin 17, and if we block interleukin 17 upstream here by blocking interleukin 23 by using Guselkumab, Tildrakizumab, and Risankizumab. Okay, so when we use these three blockers on interleukin 23, we are going to block interleukin 17, 22, and further increase of TNF alpha. We are clear on that, and that's how these biologicals stop the pathomechanism or the inflammatory cascade in psoriasis. So now what we're going to do, we're going to discuss these three biologicals together and separately also. Okay, so we'll discuss Guselkumab, 3 slides, Tildrakizumab, 3 slides, Risankizumab, 3 slides. And when we'll be discussing about contraindications, side effects, or vaccinations, and all sorts of things, we're going to discuss them together because it's same for all three. Okay, so let's start with Guselkumab. Now, Guselkumab is a IgG1 lambda monoclonal antibody against interleukin 23. Okay. Now, its subcutaneous or IV doses are available, but what we use or what we generally use around the world is the subcutaneous variation. The IV variation is not used. The bioavailability of subcutaneous dose is 49%. Peak concentration is reached in 2 to 7 days, an average of 3.2 days. Half-life is 15 to 18 days, and metabolism and excretion, like all IgG molecules, is unknown, but it is postulated that it gets degrades and then excreted by the kidney. Okay. Now this is the regimen that is to be used in patient of moderate to severe psoriasis. We get pre-filled syringes of Guselkumab of 100 mg per ml, and 100 mg is given at week 0, which is the day 1 of patient. Then after 4 weeks, and then every 8 weeks we give subsequent 100 mg till the psoriasis is resolved. Okay, so every green box is 100 mg of Guselkumab. 100 mg Guselkumab. Okay, so We give dose at week 0. After 4 weeks, we give it at 4th week. Subsequently, every 8 weeks, we keep on giving Guselkumab 100 mg till psoriasis is resolved. We are clear on that? So, 100 mg week 0, 100 mg week 4, 100 mg every 8 weeks. Okay. So, multiple trials have been done for Guselkumab, and the most famous one is the Voyage trials. Okay. And Voyage trials compared it with placebo and other biologicals also. Now, improvement in those trials continued and reached the peak levels at week 16. Okay, that means roughly about here. Roughly in between these two doses, roughly about here. Okay, so at week 16, it was found that PASI 90, that means 90% reduction from the baseline PASI score, was found to be in 70 to 90% of patients. Okay, so it was found that at the end of week 16, 70 to 90% of the patients will have at least 90% reduction in PASI. We're clear on that? If there is no response at week 16, stop the drug. Clear? So you can also add it to it that maximum patients are going to respond very significantly at week 16, and if it doesn't respond at the end of week 16 of dosages, stop the drug. Okay, that means it's clearly not working. Now, efficacy was found to be as quick as at week 2. That means when you start the medication, roundabout at this time, it had started showing its clinical efficacy. So, as early as week 2, you can see the benefit. The patient can see the benefit, and especially at difficult to treat areas that include scalp, hand, and feet. So, palmoplantar psoriasis and scalp psoriasis, or these areas when they are involved are somewhat difficult to treat, and Guselkumab showed significant resolution of psoriatic plaques at these areas. Clear? So let's move forward. Now, before we move forward, remember that Voyage trials have compared Guselkumab with other biologicals. It was found to be superior to Ustekinumab and Adalimumab. Okay, so let's go forward. Tildrakizumab is the second biological or interleukin 23 inhibitor that we're going to discuss. It's a humanized from murine source monoclonal antibody. If you don't know what we mean by murine or humanized, go and see the video on biologicals and biosimilar where I've discussed how these molecules get their name. What do we mean by humanized or murine derived or everything? Okay. Now, Tildrakizumab comes in 100 milligram pre-filled syringes. The bioavailability in different studies was found to be ranging from 73 to 80%. Now, these studies mention that 80 milligram is for 80% is for 50 milligram and 73% for 200 milligram. And the product insert mentions it as 50 to 73 milligram, and it doesn't mention the dose. So if I don't, it's not going to come into any exam, but just remember it's round about 70% to 80%. So that you can just remember it. The peak concentration is reached in 6 days. Half-life ranges from 20 to 26 days, somewhat similar to Guselkumab. Average is 23 days, and metabolism, the same line is going to get repeated. The regimen that we use for Tildrakizumab and psoriasis is 100 mg at week 0, then at week 4, and then 100 mg every 12 weeks. Now remember in Guselkumab, this was 8 weeks. Okay, so this is a difference. In Tildrakizumab and Risankizumab, the interval is 12 weeks. So remember that this 12 weeks is important. Okay. So initially we give one dose at week 0, then wait for 4 weeks and give the subsequent dose. So every blue box is 100 milligram of Tildrakizumab. Okay, let me just write clearly. 100 milligram of Tildrakizumab. After 4 weeks, we give the second dose. Then every 12 weeks, we are going to give subsequent doses till psoriasis is resolved. And as we have mentioned, it comes in 100 milligram per ml pre-filled syringes. We are clear on that? Now here, what the different trials mention, and the trial like we have voice trial for Guselkumab, we have resurface trial for Tildrakizumab, in which it compared 100 milligram of Tildrakizumab and 200 milligram of Tildrakizumab with placebo. Okay, that this is the resurface trial. Now, resurface trial showed that at week 16, which is roughly here. Okay, so at week 16, PASI 75. So we are discussing PASI 75. Remember, at week 16 we were discussing PASI 90 in Guselkumab. So PASI 75, that is 75% reduction in baseline PASI score, was seen in 60 to 65% patients. Okay, and it in as per the resurface trials, Tildrakizumab was found to be better than TNF alpha inhibitor etanercept. So etanercept was found to be somewhat inferior, slightly inferior to Tildrakizumab in head-to-head comparison trials. So we are clear on that. So this I'm just giving you some extra points so that you may write if any kind of question is ever asked. So after Guselkumab and Tildrakizumab, we come to Risankizumab. Now, Risankizumab is a IgG1 humanized monoclonal antibody against IL-23. It's made by recombinant DNA technology. Okay, so it's made by recombinant DNA technology. It comes in pre-filled syringes, and each syringe has 75 milligram. One thing to note is that the dosages that are used in psoriasis for Risankizumab is 150 milligram. That means at every instance you have to give 2 injections because each injection has 75 milligram. Okay, so Risankizumab is given as 2 syringes at every instance of its regimen. The bioavailability is about 89%. Peak concentration is 4 to 10 days. Half-life is same as Tildrakizumab, 20 to 28 days, average 23 days. And metabolism and excretion is same as all other biologicals, unknown, postulated to be through kidneys. Clear? The regimen that we follow is 150 milligram, that means 2 syringes at week 0 and 4, and then 150 milligram, again 2 syringes every 12 weeks. Same as Tildrakizumab, the only difference is Tildrakizumab was 100 milligram every time, Risankizumab is 150 milligram every time. Clear? So we give 2 syringes at all intervals. Each yellow box is 75 milligram of Risankizumab. So 2 syringes are going to be 150 milligram. So 150 milligram at 0 at 4 weeks. Then subsequently every 12 weeks we are going to give Risankizumab 150 milligram till psoriasis is resolved. So remember, 2 syringes are used at every instance. Clear? Now the name of that trial, it has underwent many trials. It is Ultima, Invent, Enhance. These are the 3 trials that Wolverton mentioned, and they have compared using 150 milligram versus 200 milligram, different type of doses, and then they have came to the conclusion that 150 milligram is the dose that we have to use. Okay. Again, we continue the doses, the biological till week 16, and if there's no improvement or no significant improvement, we can stop and look for other modalities. At week 16, 70 to 75% of patients will have PASI score of 75. Okay, so PASI 75 is achieved in 70 to 75% of patients. Clear? Which is same as Tildrakizumab. Clear? And these all trials have found Risankizumab to be superior to Ustekinumab and Adalimumab. Okay, so remember, the only difference between Guselkumab, Risankizumab, Tildrakizumab are the doses and the interval. Guselkumab every 8 weeks you give, and Risankizumab, Tildrakizumab every 12 weeks you give. That is the one of the major differences. Doses are 100 mg for Guselkumab, 100 mg for Tildrakizumab, and 150 mg for Risankizumab. Clear? Let's move forward. we have discussed about three biologicals, their different regimens that we use in psoriasis, and from henceforth we're going to discuss all three of them together because 99% of points are similar for all three of them. Okay, so for storage, you don't never ever shake the vials. Never shake any vial which has proteinaceous components like IgG1. Remember last week we discussed about Secukinumab and I told everyone that it has to be gently rolled between the fingers at 45 degrees. So, and all other biologicals are in pre-filled syringes, so you don't need to roll them. Just make sure that you never shake them. Examine all the syringes for particulate matter. Storage is again 2 to 8 degrees Celsius in refrigerator. Store in the original carton, protect from light, do not freeze. If it gets frozen, you cannot use. Do not use after expiration date. That is similar for all other biologicals and same for these three also. Baseline investigations are also same. Routine investigations, screen for tuberculosis, screen for any infection, screen for viral markers like Hep B, Hep C, comorbidity like HIV. Any sign of infection has to be properly evaluated and ruled out because you cannot give biologicals when there is an active source of infection. Now, before administering any of these biologicals, you have to wait for 30 minutes. When you take the syringes out of the fridge, keep it outside at room temperature for 30 minutes. Now it varies. Some of the biologicals mention 15 to 30 minutes, some mention 30 minutes. So it's safe that you can keep them out for 30 minutes and then consider injecting. Do not remove the cap or cover. Always inspect them for particulate matter. Slight particulate matter is always there because these are proteinaceous compounds, but see if it's more than the usual. Any discoloration has to be looked. Now, all of these biologicals have a slight yellow tinge to it. That is what all the product inserts describe. Personally, in pre-filled syringes, I've not been able to appreciate that yellow tinge. Maybe it's more serous fluid kind of thing. But any odd discoloration, it's better to avoid that biological. There are no preservatives in this, so discard all the unused portions. If it reaches room temperature, it has to be injected. Always inject full amount, no half-hearted measures. Now these are the pictures showing the pre-filled syringes of all three biologicals, and they have trade names which, in my opinion, has the same difficulty level as the original names. I don't even know how to pronounce Tremfya or Skyrizi. Illumia is okay. Illumia is okay. Okay. So Tremfya is Guselkumab, Skyrizi is Risankizumab, and Illumia is Tildrakizumab. Okay. So just to show you that different boxes then they come in. Now this picture I've taken from product insert of Illumia, which is Tildrakizumab, which just shows the various parts of the injecting self-filled needle. So it has a plunger, a finger grip to hold onto. This dose window is transparent through which you can examine the biological. You can examine for particulate matter or any discoloration. The needle guard and the needle cover. Remember that needle cover has to be removed only just before injecting. Okay, it's a protective latex including cover, latex. So you remove it and inject it. Okay. Now, injection techniques for all three biologicals, they are given subcutaneously. After inspecting for particulate matter, allow it to thaw for 30 minutes at room temperature. Then remove the rubber cap, inject it, and complete syringe to activate needle shield. That means you have to push it to the maximum extent and you will hear a click. And that click is the needle guard either coming out to protect the needle or the needle getting inserted back into the syringe so that it doesn't cause needle stick injury. Now, for Guselkumab and Risankizumab, it says to inject at 45 degrees, but the diagram that I saw for Tildrakizumab showed it being injected 90 degrees. Frankly, I don't think so. It would make much difference. Just remember that the amount of drug should go into the subcutaneous. Okay. Now, this image I've deliberately taken from Tildrakizumab, which shows the 90-degree injection, and you can see that the needle after completion of injection is going to go inside. Okay, so just take the site which you want to inject, just bunch it up, pull up the skin a bit so that you can inject it directly into the subcutaneous. These are the injection site which I have taken from Guselkumab product insert. These are all the sites where you can give subcutaneous injection, along with just one mention that the periumbilical area you have to leave around 1 inch to 1.5 inch from the umbilicus before injecting. And remember, whenever you're going to inject any kind of biologic for the patient, always mark the site that you are injecting and mention it in the OPD card or mention in the records of the patient that at this date, at this instant, I injected this dose at this site. And that site has to be properly mentioned and possibly marked on a body outline diagram so that the site is not repeated. On all subsequent injections, you need to rotate the sites. Okay, keep on changing sites. Do not inject if the injection site is red, painful, tender, firm. Injected only in the healthy skin. The skin should be free from psoriatic plaque also. Okay, keep on changing the sites for every subsequent injection. We have seen how these three biologicals act. How do we give them in patient of psoriasis, and how to actually administer these biologicals to your patients. Now, from henceforth, we'll be discussing these subsequent topics regarding contraindications, infections, tuberculosis, other contraindications, vaccinations, by discussing these three biologicals together because it's same for all three of them. Now, no contraindications are listed, there are no boxed warnings, but we just have to be careful about some of the aspects regarding any active infection have to be ruled out and treated first. So there may be an increased risk of common infections like GI, URTI, dermatophyte, HSV. Okay, infections like tuberculosis, especially in our population in India, where tuberculosis is endemic to a very high extent. So every patient who is going to receive these three biologicals, or for that matter, any biological, should be screened for tuberculosis. So you can use Monto, IGRA, chest X-ray to find out if there's any focus of latent tuberculosis. If you want to know what to do if you get any foci of latent tuberculosis, we have discussed a detailed flowchart in initial videos which were on Adalimumab and Infliximab. In those presentations, I discussed the flowchart on how to go about your patient when you're screening them for tuberculosis. Okay, so you treat the tuberculosis. If it's an active tuberculosis, you treat with ATT. If it is a latent, then you give prophylaxis with isoniazid. Monitor any new development of tuberculoid symptoms so that you can treat them, stop the biological, and treat them at that instance only. The pregnancy status, there is no historical rating. There is no ABCDX rating of for biologicals because they were given approval after the rating system was discontinued, and there is no newer rating because there is no data as of now. So that's the easiest form of pregnancy category to remember. There is no data, no rating. Okay, let's go forward. Now, infections are the contraindications or something to be careful about. We should not have any kind of foci of active infection. It has been reported that 55 to 65% of patients will have at least one adverse event. Now, these adverse event can be as inconsequential as URTI or nasopharyngitis, or as severe as myocardial infarction or hypersensitivity reaction. So what do we mean by pooled data? Pooled data is because I've read 2-3 articles about each of the biologicals. I've read around 3 textbooks, and I've tried to pool and give us just a general range of them so that you need not remember each and every ranges. But each and every range for each and every biological is round about the same. So you can combine all the data as a pooled data and say that 55 to 65% will have at least one adverse event. Most common adverse events were URTI, nasopharyngitis, injection site reactions, roughly about 1/4, diarrhea, but all of these side effects were comparable to placebo. So they were more than placebo, but not significantly more. Candidiasis and neutropenia are also separately mentioned in product insert of these biologicals. Remember that Candidiasis and neutropenia were also specific side effects of secukinumab. And why is that? Interleukin 17 is responsible for activity against candidiasis and neutropenia, and interleukin 17 is localized to the orificial sites like the mouth and other entry sites, and interleukin 23 leads to formation of interleukin 17. So when we block 23, we block 17. Okay, so that's why candidiasis and neutropenia are mentioned. The rate of discontinuation ranges from 2 to 3.5%, but in all the studies, it has been reported to be lesser than 5% at week 48. So that is also pooled data. Regarding tuberculosis, as we have mentioned before, we have to screen all patients. No activation has been reported. If I remember correctly, one study had a lot of patients and 72 of them had foci of latent tuberculosis which were given prophylaxis and then biological. And none of those patients has an activation tuberculosis. Okay, so no activation has been reported. These three biologicals have been better than TNF-alpha inhibitors. And if you find a foci of latent tuberculosis, even single isoniazid prophylaxis for 6 to 9 months is adequate. Okay, you have to screen all patients prior. That goes without saying. Other contraindications and warnings include hypersensitivity reaction to either the biological or other products which are added to biological. There are many other chemicals which are added like sorbitol, citrate, and if the patient has any kind of hypersensitivity reaction to each of these molecules, they can have a hypersensitivity reaction to the entire biological syringe. Okay, myocardial infarction have also been reported in their product insert, and it has been said that it is not more than placebo. But since there was, if I remember correctly, one mortality due to myocardial infarction or an adverse cardiac event, and adverse cardiac events are associated with the use of all biologicals, it's always better to screen for any pre-existing heart condition and to be on the lookout for new development of symptoms which may point towards a cardiac issue or not. Non-melanoma skin malignancies, which include SCCs and BCCs, have been reported. Not more than the general rate of SCC and BCC, but again, we need to keep a lookout on patients. Now, all of these psoriasis patients may have received, phototherapy in the past, or methotrexate in the past, or other biologicals in the past. So, because of that, the risk of developing non-melanoma skin cancer are again increased. So we need to just keep a lookout on them. Other malignancies. Now, some patients in some of those articles or studies mention breast malignancies, stomach malignancies occurring in patients receiving the biologicals. Whether it's a chance occurrence or is it because of the biologicals that we are giving, the articles are not sure of that. So we just have to keep a lookout on development of newer symptoms which might point towards subsequent malignancy and then treat as required. Anti-drug antibodies. These are proteinaceous molecules, and whenever a proteinaceous molecule is going to be injected inside the body, it will lead to formation of antibodies. Okay. So the rate of antibody formation is roundabout somewhat similar. It is 5 to 6% at week 48 for Guselkumab. It is about 6.5% at week 48, or it can be as high as 24% for Risankizumab. Okay. Now remember that all antibodies which form, or all the patients who form antibodies, the antibodies might not neutralize the biological. Okay. As we had discussed in the video on infliximab, the development of anti-drug antibodies will decrease the efficacy of infliximab. But for these biologicals, as per the studies which have been conducted till now, the efficacy was not found to be decreased clinically. Okay. For example, in 6.5% of patients developing anti-drug antibodies, 2.5% had neutralizing antibodies. Okay. For Risankizumab, 24% of patients develop antibodies and 14% of the patients had neutralizing antibodies. What do we mean by neutralizing antibodies? That means these were those antibodies which were actively engaging with the biological and were not allowing it to act. They were neutralizing the biological. Okay. But even after neutralization, the clinical efficacy was not that much reduced in those patients. But remember, if the biologicals do not show improvement, of show improvement in psoriasis at week 16, we should consider, or not consider, we should stop the biological and look for other modalities of treatment. And production of anti-drug antibodies is one of the factors which might lead to no improvement in psoriasis. For vaccinations, remember that pediatric patients should be brought up to date, but the use of these biologicals in pediatric population is not FDA approved. They are only isolated case reports. Like all other biologicals, the vaccination schedule should be up to date. They may receive concurrent vaccination, but not live vaccines. So you can give other vaccines which include dead organisms or subunit vaccinations or mRNA vaccinations, but not live vaccinations. And there is no specific data, but theoretically, the seroconversion or development of protective antibodies might be less in these patients who are receiving biologicals. Clear? So with that, we finish this video on IL-23 inhibitors, Guselkumab, Tildrakizumab, and Risankizumab. And with this video, we're going to finish the series on the use of biologicals in psoriasis. And I've tried to be as detailed and as extensive regarding these biologicals. I've tried to be very lucid and very simple in presenting this data so that we are easily able to memorize or remember, or at the end understand the working of these biologicals and then decide what all to give on in which patient. Now, coming to the use of these biologicals, one suggestion was made in the last video by one of you that I should also cover various guidelines for psoriasis, and I agree with that. Since these videos are more theoretical, just to make people understand what do we mean by these drugs and what are the theoretical aspects of these drugs, discussing guidelines will tell us more about how to use those drugs, when to start, when to stop, what to do with these drugs. So next week, I'm going to make a video on other different guidelines, which will include American Academy of Dermatology, British Academy of Dermatology, and maybe one or two guidelines from the Indian subset regarding the use of biologicals in psoriasis, so that we can have a certain basic understanding of usages of all these different biologicals that we have discussed till now. So if you have followed this series regularly, you will now have a better understanding of adalimumab, etanercept, infliximab, certolizumab pegol, ustekinumab, secukinumab, guselkumab, risankizumab, tildrakizumab, and few other like ixekizumab and brodalumab, which we have discussed only one or two slides. And with this, you will have a good grasp on the usage of biologicals, their different mechanism of action. And if you combine this knowledge with the pathomechanism of psoriasis video, I think I was somewhat successful in covering these kind of aspects by this video series. So next week we'll meet again. We'll discuss the different guidelines and increase our knowledge parameters. Till then, if you have any doubts, you can just email me directly, or you can comment it below the video, and I can look into it and then subsequently learn about how to make these kind of video series better for understanding different drugs in dermatology, and how to make myself at least better in explaining things and making things very simple. Because what I have found while dealing with biologicals is that every biological is different and every biological is same. So we just need to know what are their individual differences and what are their individual similarities. And after understanding that, we can easily go forward with using one or the other in our patients. So with that, I will end this presentation, and we'll meet again next week with the guidelines. So adios. Make sure you practice sun protection, sunscreen, and moisturize your skin. Bye bye.